Good afternoon, everyone, and welcome to the AVA Webinar Wednesday series. I'm your host, Jason Novick, the AVA Webinar Coordinator. So before we begin, I'll share a couple of procedural things. First, the chat function has been disabled on the Zoom webinar platform. So throughout the presentation, please use the Q&A function to pose questions to our speaker, Dr. Lynn Haag, and then we will make time to discuss your questions in the Q&A portion at the end of this webinar. And we will also share a feedback survey to please complete at the end. Also, please note that this webinar is being recorded and will be posted to Ava's YouTube channel shortly, so you can revisit and share this in our previous webinars. And welcome to today's webinar as part of Ava's Webinar Wednesdays. And I'm joining you on behalf of the Alliance Against Violence and Adversity, and I want to begin by acknowledging that on a national level, we encourage all Canadians and visitors to Canada to learn about the Indigenous peoples of the lands on which they live, work, and visit, and become engaged allies together. And we, as Canadians, in the spirit of truth and reconciliation, respect the self-determination of First Nations, Métis, and Inuit peoples, and their rights and responsibilities in cultures, languages, and the pursuit of wellness. The focus of today's webinar is helping the helpers, recognizing and responding to brain injury from intimate partner violence, featuring Dr. Lynn Haag, a CIHR fellow and contract faculty member with the Faculty of Social Work at Wilfrid Laurier University and part of the Canadian Centre for Intimate Partner Violence and Brain Injury. Dr. Haag research program is focused on women survivors of intimate partner violence-related brain injury, or IPV-BI. Dr. Haag is committed to improving outcomes through direct practice, innovative research, and professional education, believing that increased knowledge and understanding in the community is important. As someone with lived experience of brain injury, she has been a guest speaker addressing issues of disability, brain injury, and marginalization for a variety of international academic, professional, and community-based organizations. Thank you so much for joining us today, Dr. Haag.
Thank you very much for having me. Um, so I'm excited to have the opportunity to create this webinar and to share some information today and take us through a bit of a quick dash through the intersection of intimate partner violence and brain injury. And as noted, the name of this talk is Helping the Helpers. So really my work is about focusing on the front line in a variety of contexts, um, frontline workers in the intimate partner violence or gender-based violence sector, folks offering healthcare services, policing, first responders on scene, all of those folks. All of you are involved in helping professions of some sort or another. And my job really is to support you in being able to recognize and respond adequately and effectively for women who are experiencing brain injury as a result of intimate partner violence. I'd just like to take a quick moment here and acknowledge my gratitude to the Indigenous communities of this land for their stewardship and care in keeping it for the generations to come, and to recognize my privilege in being here and my promise to do my best to work and live in harmony with and support of those who were here first. I recognize the loss, vulnerability, and ongoing injury experienced by many through the process of colonization. And I recognize my role in it here and will do my best to end its perpetuation and seek spaces to prioritize and privilege those who have been traditionally excluded. Many of the women that I speak to in the process of my work are unequally harmed through the impacts of colonization, particularly Indigenous and racialized women. I acknowledge that, and I'm committed to doing what I can to change it. So I am a very lucky member of a 5-person team from across this country that was put together to and funded by Public Health of Canada to build awareness and service provider capacity to address IPV-BI in Canada. The principal investigators are Dr. Angela Colantonio from the University of Toronto. She brings an occupational therapy lens and holds a Canada Research Chair, Tier 1 chair in brain injury in underserved populations. I'm coming to you from Wilfrid Laurier University in Kitchener-Waterloo in Ontario. I'm from a social work faculty, so I bring that sort of practice-oriented lens to the conversation. Dr. Mike Ellis is a neurosurgeon from Winnipeg, Manitoba, and he is offering direct practice to survivors of intimate partner violence and brain injury, particularly with a focus on serving Nunavut and Inuit women. And Dr. Paul Van Donkelaar and Karen Mason are our BC Coast team. They are coming from the University of British Columbia, Okanagan, where Paul is in kinesiology. I used to be a sport concussion guy until meeting Karen Mason, who was at the time the executive director of the women's shelter in Kelowna. And the two of them forged a partnership, both in life and in work, understanding that there was this intersection and more work had to be done here. So this team brings an awful lot of expertise, number of different perspectives to the table. We span both straight research and practice, and we really work hard to try and address some of these gaps. We couldn't do the work that we do without our fantastic team behind us. Amy Moore is our project coordinator, keeping us on track. Kelsey Helm makes sure that we're managing the budget and doing all the report work. And then Lizzie Berg, Robin Mahood, and Olivia Steinberg have each been contributing through research associate roles in a variety of different ways, making sure that the project runs smoothly, that we're able to get the deliverables out, and making sure that everything looks really great and has all that branding to go with it. I'm equally thankful for our community partners. This work is rooted in community. It's intended to develop solutions that make it out into the community within months, not years of the project being in progress. And we work with partners from all different kinds of sectors, different sort of types of folks, product users, product designers, service users, folks working in shelter organizations, in healthcare, folks working in community-based organizations who are advocacy organizations. We also do a lot of work with survivors and really prioritize space for survivors to tell us what they're experiencing, what are they needing, and how can we address those things. I'd just like to put out a quick thank you to our content contributors. The SOAR project out in British Columbia from Paul and Karen has contributed quite a bit of material, as well as the Abused and Brain Injured Toolkit. Dr. Colantonio and I are the architects of that toolkit, along with community partners working in that sector as well. So let's dive in now and talk a little bit about the intersection of intimate partner violence and brain injury. Abuse itself, when people want to talk about what is intimate partner violence, and we sort of need to settle onto a definition, abuse is an incident or pattern of incidents of controlling, coercive, threatening, degrading, and violent behavior. There are many different types of abuse, including emotional, financial, and verbal. However, I focus on physical abuse because I'm focused on the brain injury as a result of that. So I'm looking at that for that physical event that would have caused a brain injury. It's really important to understand that intimate partner violence can happen to anyone. Folks from across the sex and gender spectrum experience IPV and engage in violent behavior. So it's not just one group inflicting violence on another group. This really happens across all the spectrums. And it doesn't matter how much education you have or how much money you make or where you live, although some people are more likely to experience IPV than others. In Canada, as I mentioned earlier, Indigenous women and girls and racialized women and women with disabilities all experience higher rates of IPV. While IPV does happen to men, and it's important to recognize that, statistically, IPV-related brain injury is far more likely to happen in women than in men, which is why my work and my language focuses on women survivors. 44% of Canadian women report having experienced IPV at some point over their lifetime, and 23% are reporting physical IPV. Something that's really important to note there is that that's a reported statistic, and we know that that tends to be much lower than the actual occurrence within the society. Because of that, it's important to see IPV as a public health issue rather than just a social one, because it can provide new ways for us to destigmatize and provide broader access to care and supports. 92% of violent encounters during intimate partner violence will include hits to the head, face, and neck, including non-fatal strangulation. So we know that there are so many of these encounters are causing the kinds of blows to the body that can result in a brain injury. And we know that the knowledge and awareness are patchy at best, with no formal training opportunities available. The way we approach provision is strictly hit and miss. Some communities might have care for IPV or BI, but lots don't have IPV-BI specialty teams. And realistically, we have limited amounts of services across this country for any of them, with a demand that seems sadly to be growing. I want to just take a minute for those of you in the room who are specialists in healthcare, who understand the brain injury piece really well. I want to take a minute and just bring everybody up to speed on the IPV piece and take a look at some of the ways that we as a society shape this and respond to this. And for a long time, the heading on this slide used to say, why does she stay? Or why doesn't she leave? And I think we need to stop asking questions that way. We need to stop saying, why does she stay? It puts the focus in the wrong place. We should be asking, I mean, realistically, we should be asking, why do people use violence and how do we change that behavior? But from the perspective of what I'm talking about in brain injury, we need to look at what prevents her from leaving. When we look at why does she stay as language, it subtly puts the responsibility on the victim. It sets us up to consciously or unconsciously add shame and blame. And it's important to think about what is stopping her from leaving. So, what prevents her from leaving? And come to an understanding that is rooted in empathy and compassion. There are lots of legitimate reasons why women are prevented from leaving, and we need to look at those as barriers to her safety and find ways to address them rather than see them as behavioral choices. So let's just take a quick look here. Some of the things that can prevent her from leaving. Number one, you're looking at fear. And that is a very realistic fear. One of the things that we know is that women are most at risk of homicide, intimate partner violence related homicide or femicide at the point in time in which they leave or shortly after. So it's not a misplaced fear that she's experiencing. That's legitimate. And she is best placed to assess her safety and that risk better than anyone else. There could be a lack of finances or lack of support at play here. An abusive partner will immediately seek to isolate a woman through cutting off financial independence, making sure that she is relying on them for financial costs and expenses, as well as cutting you off from a lack of support, friends, support, or family. So both of those things could be preventing her from leaving. There are often children involved. This may well be the other parent to her children, and she wants what's best for her children, and she wants to provide. Um, she wants to make sure that they have access to their entire family and their entire support system. She may love her partner. We don't get to choose who we love. Life would be a lot simpler if that was always the case, that we could just pick people who were healthy for us. But that isn't how human beings work. We love who we love, and we need to have compassion for other people around that. People who engage in violent behavior in a relationship aren't like that all the time. It's a cycle. It comes and it goes. There's an awful lot of apology. There are periods of time where everything is perfect and your partner is supportive and remorseful for past events, is promising it will never happen again, is being an active parent, is supporting you in whatever it is that you're trying to do. And then tensions build and that need for power and control comes forward again, and there's an outburst. And so you see things happening in a web, in a sort of a wave pattern. And it's easy. You're invested in a relationship. You want to stay in it. And it's easy to try and see the good in your partner rather than see the violence and the damage that it's doing. So all of these things together can really play into why why they're prevented from leaving. The other piece that we're really interested in that we want to talk a little bit about today are those cognitive impacts. If there has been a brain injury as a result of exposure to physical violence, what is happening with the brain and how is that having an impact in the situation? So, just to keep us all on the same page and put in a little bit of baseline data here, I just want to take a look at the numbers. So we know that research is suggesting between 19 and 75% of women exposed to physical intimate partner violence have a possible brain injury. The spread in there, the 19 to 75%, the spread is so large because the field is very new. This population of brain injury survivors is really hard to get access to. And we have some challenges, some research methodology challenges with the samples because they're either too broad or too narrow. Just from a simple perspective, if I stand on a street corner and I ask every woman who crosses my path whether or not they've experienced intimate partner violence, whether that's been physical, whether or not a couple of questions later, do I think there's a possibility of a brain injury? Because I'm standing on a street corner asking absolutely everybody who comes across me, that's when I'm going to start seeing that lower percentage rate. If I go to an emergency room and I ask women who come in with visible evidence of bruises to their face or broken bones in their face, I ask them the same sort of questions. I'm going to start seeing a higher rate of those folks who actually have been coming in because they've experienced intimate partner violence. If I were to go to a shelter and talk to women who are there for the first time in the shelter and ask them the same questions, I'm going to get a little bit higher still, but I'm still not going to hit those really high numbers. And if I go to the shelter and I only ask women who come in repeatedly, who are we know have a long history, and I ask those questions, I'm definitely going to start seeing my 75% and even higher. And we do have some indications of those higher samples with 100% even in the literature. It really comes down to where did we ask the questions, who did we ask them of, and how likely were we to be talking to a subgroup of women who had experienced some of the most significant exposure levels to physical violence. So, for me as a researcher, I like to be sort of cautious about things. And when I do the math here and sort of calculate out to get an answer of how many women in Canadian society are we seeing with this challenge, I'm going to go down the middle of that 19 to 75%, and I'm going to take 50%. So if we have one in four, and again, that's a conservative estimate, one in four women reporting physical violence over their lifetime. That's according to the World Health Organization. And we multiply that by the 50% ratio, experiencing brain injury as a result, that comes out to one in eight Canadian women with possible brain injury as a result of exposure to physical intimate partner violence. The reason that this picture that's on the screen here has the one in eight and the number one is written in pink is because the photograph was for breast cancer. That's the same prevalence rate as breast cancer in this country. And I like to highlight this for a second and let people think about that. I want you to think about everything that we know about breast cancer, all the research that goes into it, all the funding that supports that, all the medical options that have been developed in the last 50, 60 years to address breast cancer. The local sources for breast cancer support, the social services that are available, the community services that are available, the lack of stigma and shame attached to breast cancer. Nobody blames a woman survivor of breast cancer because she got cancer in the first place. And now think about the fact that none of those things can be said for women who are exposed to brain injury as a result of intimate partner violence. And yet we have the same prevalence rate in this country. So let's talk a little bit about what kind of brain injury we're looking at, because there are different types and there are very specific types that we expect to see here. There are two types that we would expect to see in this particular group of survivors. The first one would be traumatic brain injury. That's an alteration in brain function or other evidence of brain pathology caused by an external force. So something has to come into contact with your brain in some way, shape, or form. In the context of intimate partner violence, we generally see that from someone who's been punched or kicked in the head, who's been thrown up against obstacles, who's been shaken or hit with an object. The other type of brain injury that we see is something called hypoxic ischemic brain injury, and it happens through a loss of oxygen and or blood supply to the brain. During IPV, we would expect to see that from someone who had been strangled or had been suffocated with an object. I think it's really important for folks to know that this is an invisible injury. And I'm gonna highlight something. I'm gonna go back to the introduction where I was introduced as a speaker and highlight the fact that I'm a survivor. So I was injured in a car accident 24 years ago. And most people would not have any idea that I have a brain injury. The damage is permanent. I fall on a sort of mild to moderate level of injury, and I experience challenges on a day-to-day basis. Lots of the things that are in this list here, I certainly live with regularly and have done for 24 years. And I say that because I think there are two reasons I think it's so important to be open about that. One is I want you to see how easy it is to not see a brain injury and to miss that in the folks that you're trying to support. And the other reason is it's just a little shout out to folks who might be in a position like myself to say there is life and there is hope after brain injury. It may not be what you had before. It may be different from what you walked into that with, but life can be positive and it can be good after brain injury. And I think it's important that we tell people that throughout all the bad news that we have about this intersection, the good news is there's always room for improvement, even if we can't repair the wiring necessarily, depending on how long it is post injury. There are ways to improve your quality of life, and there is a lot of hope. So it's worth reaching out. It's worth understanding this. It's worth supporting people 2 years in post injury, 5 years post injury, 10 years, 20 years. We can improve things for folks for a long way down the road. So let's take a look at these different challenges. These are three families of challenges that we see typically in folks who have a brain injury. These lists were made for folks for the most part. This is straight up brain injury information. This is not specific to intimate partner violence survivors. And I want to talk a little bit about how these things have an impact for a woman survivor. So, direct impacts like these will interfere with her ability to assess her safety, to plan and execute a safety strategy, and they will shift how she's able to interact with law enforcement, justice, and CAS personnel. Ongoing undiagnosed and unsupported symptoms like these will prevent her from obtaining and maintaining employment, as she is unlikely to receive accommodation for disability related challenges. They also make it more difficult to accomplish everyday tasks like grocery shopping, running errands, meal preparation, laundry. And once someone has struggled through all of these barriers, there's little time or energy left at the end of the day to engage in activities that will improve her well-being. I want to take a second and think a little bit about a couple of things here. I want to think about a first responder at the door. So imagine you're a police officer at the door and you know you're coming in on a domestic violence call and you're immediately scanning the situation. You're bringing in all kinds of information. The woman who's talking to you, she doesn't quite make eye contact with you. Her speech is slurred a little bit. She's a little unsteady on her feet. Her timeline keeps changing when she's relating details to you. Some things, they happen in a linear fashion, and then she'll bounce forward or backwards a couple of hours in her story. People come and go in her story. The details change a little bit. And you're looking around you and you see on the coffee table behind her in the living room, you see maybe some couple of beer bottles or a little bit of some drug paraphernalia. And immediately you're thinking, right, everything in front of me is talking to me about drugs and alcohol use. And every decision that's made from that moment forward puts her on a path, on a trajectory to consider criminalized behavior as part of what is happening, if not the defining characteristic of what is happening. If I'm standing on that doorstep and I'm looking at all of the same things, my question is, has this woman just had her head bounced off a wall and is she experiencing a concussion? You see exactly the same kinds of behaviors from someone who is concussed or has a history of brain injury. And so the minute that thought surfaces, there's a different trajectory. Now we're looking at medical care and assessment and treatment. And you can see how the path diverges and what might be an opportunity for support and diagnosis and treatment now becomes something totally different. So it's so important that we understand what we're seeing, we can recognize and respond adequately. Other ways in which this is relevant, if you're in the intimate partner violence sector, if you're doing safety planning with women, one of the things that we really highlight for you is to take a consideration of implications of memory, organization, planning skills. She may well remember what you're talking about in the moment that you're doing that planning, but she may not remember 5 minutes later when she leaves the office. It's important to work on some different memory techniques that you can use in order to solidify those pieces of the puzzle. It's important to talk about how can you use things like writing things down in lists. How is that safe or not safe for her to do? And just to take into account all these little different things. So I like to talk about 5 practice challenges. What are the big things that are preventing you from being able to do the helping work that you're trying to do to the best of your ability? Number 1 is communication. Folks with brain injuries communicate differently. They have difficulty with concentration and paying attention, especially in noisy environments and for sustained activities. We tend to have slower processing speed, so we have reduced rates of speed. We process less information and we store less information. We also have more difficulty with complex tasks. Our memory can often be impacted. So, and that's about both the storage part and the recall. I often talk about it like having a Swiss cheese memory where there are just holes all over the place where things just never got stored. And we do have communication problems, and those problems are not always obvious. So they tend to be more subtle. They are often misconstrued as poor attitude, disinterest, disrespect, low intelligence, or even substance use. And what happens with these communication challenges is that they eat away at the relationship between you and your client. Whatever profession you're in as a helper, you rely on that relationship. Without trust and communication, both parties become distanced. The worker is often frustrated because the client they can't even be bothered to help themselves. Why should you be bothered to take your time and trouble to help them? And from their perspective, the client often senses that they're being judged or they're not being believed or they're always being told the same thing, but it never changes in terms of how they're being helped. There are lots of different ways in which that relationship can degrade really, really quickly. Without the relationship, we have nothing. There's no pathway for support and care. So, understanding the communication piece, understanding how that shifts, seeing that these are not behavioral choices, these are related to a disability and an underlying physical condition. There's a really great analogy that I like to give people, and that is imagine you're sitting at your desk, whatever your profession is, you're sitting there. Somebody who uses a wheelchair rolls up to your office, knocks on your open door, and says, I'm experiencing intimate partner violence and I'm having some trouble with these different things. I'd really like to talk to you about it and get some help. Now, what's your reaction going to be? You are not going to say to them, absolutely, I'd be so happy to help you. Could you please just stand up, out, get up out of your chair, walk across the room and sit down and talk with me over here? That's not going to happen because you recognize that this person, for whatever reason, uses the chair because they need to use the chair. So you're going to make sure that there's a pathway for them into your office so that they can receive your services. The problem is we've been doing exactly that on a brain injury level. We've been creating all our services based on the assumption of full cognitive capacity. And once that capacity has been impacted by injury to the brain like this, we can no longer make that assumption. Your number 2 problem is that post-traumatic stress disorder and brain injury look very, very similar. You can see in the dark purple center here all the different things that can occur in both PTSD and brain injury. The good news is we've got those little bits hanging out on the outside edges that belong to either one or the other. The reason this is such a big problem is because if you only ever treat the situation from one perspective or the other, you're always going to be overlooking the other condition. And that condition is going to be significantly undermining your ability to offer services and her ability to take them up. We need to tease apart when we're dealing with mental health and when we're dealing with brain injury. And we need to be aware of the interconnection between the two, how they exacerbate the other condition, and how they can be supportive, and what are the ways in which we can foster that. Your number 3 problem here is substance misuse. We have a high rate of substance misuse within traumatic brain injury survivors, regardless of how they get their injury, up over 80%. And we know that IPV-related brain injury can present as substance misuse and be overlooked as a result. These things are important to consider. We know that this is a chicken and an egg situation. Misuse of substances can cause brain injuries, and a lack of decision-making capacity and a tendency towards impulsivity in brain injury survivors can make substance use look like a really viable option. We also have a lot of challenges rolled in with the IPV piece, where we know that abusers can weaponize the use of substances and effectively threaten, either you take this drug or I beat you. It can also be used as a way to discredit a survivor when they're speaking with health providers or legal advisors. Can be used against them in a family court situation, all those pieces. Number four is strangulation. This is an increasingly common aspect. We know that over 60% of IPV survivors are reporting having been strangled at least once in their lifetime. We know that strangulation is absolutely a high risk marker for femicide and intimate partner homicide. We also know that it can cause brain injury and death within minutes. It's because it's cutting off the blood supply and the oxygen supply to the brain through the neck, and it can do so and leave practically no visible marks. So it's really important that we raise awareness around this. We get people looking for this and seeking out information. Has a survivor experienced this? What did that look like? What can they talk to you about that? And getting a sense of whether or not a brain injury may have occurred during that event. Your last practice complication is around screening. Screening is incredibly complex. Survivors do not typically seek care for brain injuries. They're just as unaware of the connection as anyone else. Emergency rooms, primary care settings, and IPV agencies are often not well equipped to screen for IPV and or BI, let alone the two of them together. Survivors may deny abuse or injuries when asked outright, particularly if they feel it's unsafe to do so, either because the abuser is present or actively threatening them, or because previous encounters with healthcare providers and or law enforcement were not a positive experience. Providers need training to ask directly in a safe and supportive manner, and organizations need to put protocols in place to offer safe spaces for disclosure. We also know that it can increase risk for survivors. It can be used against women in family law courts. And we know that there are gaps in trauma-informed brain injury services in the community. We also have a lack of validated IPV-BI sensitive screening tools, although we are working on that. That's a little sneak piece of information for you. Just because screening is complicated doesn't mean recognition isn't important. It is critically important that we understand what's happening for the person that we're trying to help. And there are lots of good reasons for that. They're more likely to receive appropriate medical and supportive care if we understand. We're going to decrease those communication-based challenges, and we're going to allow for trauma-informed intervention to be more successful. And critically important, we're going to be building trust and rapport with not only the survivor, but also the perpetrator. If we don't support the folks throwing punches, this is never going to change. And I know that's difficult for a lot of folks to understand. We tend to demonize folks who engage in violence within their relationships. But in many, many cases, there are challenges similar to there are with intimate partner violence survivors and brain injuries. We do see a higher rate of brain injuries among the folks throwing those punches. There are lots of different reasons why this is happening. And until we support them and we create systems to give them other choices just as much, it's going to keep happening. So because I said this is a hidden condition and, what are you supposed to do? I wanted to give you a few things to look for. The highlights of this in that brain injury group, you're looking for confusion, difficulty processing instructions, that memory piece. And someone who says to you, I'm not feeling like myself, it's really, they don't know what's going on with themselves either. They just know that they don't feel normal. They don't feel like themselves. We hear that from survivors of brain injury across the board. It doesn't matter what type of injury or how they got it. When it comes to the strangulation piece, I did mention that often you will not see bruising and marks on the neck necessarily that you might expect to. So you're looking for things like that raspy voice, trouble swallowing or breathing, any scratches on the neck that might be there, and potentially a loss of consciousness or a loss of bodily functions with bladder and bowel control. The reason it's so important to see this is because folks need to seek medical attention, but they need to do so when it's safe. And that's a piece of the puzzle from a brain injury perspective. Seeking medical attention is the number one thing we tell people. But when it's an IPV context, that safety piece has to become a prime concern. These are just a few of the folks who are available to you as resources. So, your emergency room at the local hospital, you're looking for forensic nurses or sexual assault nurse examiners, SANE nurses within that environment. Family health practitioners often have a lot to offer. And then there are extended health professions that can be really helpful. So, occupational therapists, physiotherapists, optometrists, social workers, and psychologists. Now, what can you do about it? Quick 5 things that you can do to start changing your practice today. Trauma-informed practice is your number one piece. How we interact with survivors will have a direct impact on whether or not they seek help now and in the future. They already feel shame and blame themselves. They need us to not add to that. They also need us to see them as the best judge of their own actions and to recognize that nothing is simple. Their lives are incredibly complex as they do their best to balance safety up against their needs and the needs of their children and families. Even something as simple as asking a survivor why they haven't sought medical help can be seen as victim blaming. She may well be more at risk of having gone to the hospital or calling the police than if she doesn't. Trauma-informed practice helps us to recognize the effects of trauma. It allows us to emphasize physical, psychological, and emotional safety, and it meets people where they're at. And we know that women who receive trauma-informed care tend to recover more quickly. They're more likely to work with authorities, and they're more likely to report future instances, all of which will help them stay safer. Number 2, please take a look at the big picture. If we only ever look at the ears, the tail, and the tusks, we don't see the huge elephant in the room. And believe me, the elephant is there. So please step back, just take a look at lots of different things. What's happening for her? What is she reporting? Are any of those signs and symptoms coming forward in the conversations that you're having? Do you know that she has been exposed to an event of physical violence that could possibly have been a cause of a brain injury? This slide, I need your offices to look like this slide. And I know that that's really difficult to do. We're looking for you to try to de-escalate your environment and approach. It's important that everybody working with survivors of IPV-BI understand the implications of trauma. Many of us who are accustomed to working with survivors of brain injury received in sporting or automobile accidents or everyday falls. But this group of survivors is different. The mechanism of injury is extremely traumatic in and of itself, and this brings with it heightened awareness, lack of comfort in closed-in spaces, an inherent fear of other people, particularly in tight spaces, and extreme responses to physical touch. It's everybody's responsibility to become trained in a trauma-informed approach to care, whether you think you support these survivors or not. I guarantee you do. If you're supporting women living with brain injuries, you're supporting survivors of IPV. Statistically, it's impossible not to be. This is just a quick little list of things that you can do to alleviate some of these challenges, both from a brain injury perspective and a trauma piece. Dim the lights, move to a quiet, calm location. If you can't, provide earplugs, sunglasses, or a hat to help with that. Speak slowly and clearly. Check in with her about what she's understanding. Don't just ask her if she understood. Encourage rest. Call ahead with appointment reminders. There are lots of little things that you can do that don't cost anything, and you can change the way you practice tomorrow. Peer support and counseling. Hearing from other people who have experienced things that are similar to you is incredibly important and very supportive. If you can offer this in your agencies or in your context, please do. And the last thing, you're already doing it just by being here. I need you to become prepared. So you can see the little parachute there. That's just a piece of analogy for me to tell you, if you're waiting till you're jumping out of the plane to make sure that your parachute, that the seams are tight, that there are no holes in the parachute, that it's been packed into the bag properly, it's too late. At that point, you've leapt out of the plane and it's all up to the gods. We need you to be prepared ahead of time, before you're standing at that doorstep, before there's a client who's across from you and asking for help. Know who's in your community. Do some work on cross-pollination. Find out who your brain injury services are, or who your intimate partner violence sector folks are. Make those connections today before you have someone who needs help sitting across from you. We've learned a lot of lessons from existing programs. I've included this list here for you so that you can go back to the seminar and take a look and just see what's there and how you can build on these things. I want to make sure to give you a quick note on where you can go for available resources. We have now launched the Canadian Centre for Intimate Partner Violence and Brain Injury. We have access in centralized content to in both French and English. We're committed to a scientifically rigorous process in our efforts to create evidence-based resources and protocols. The center is serving as a repository for all things IPV-BI, up-to-date resources, tools, education, and community. We have the Beacon, which is our newsletter. You can follow this QR code and sign up here for that. We also offer frontline education and training, both in the communities and through some online courses. We have a knowledge implementation and translation network where we're bringing people together and fostering that community, both from a practice perspective and from a research perspective. And we're creating a lot of standardized resources. We've got medical provider resources that are giving you lists of who are the folks that you can talk to, what are the next best steps, how do you assess, what does follow-up care look like? We've got the systems of care framework so that you've got a pathway that you can now follow. What is the ideal pathway for care? And we're creating one for you that's a non-ideal. So when you don't have all those great services in your community, what do you do then? That'll also be available for you. We've got handouts that you can give survivors that both talk about intimate partner violence related brain injury, but also just talk about brain injury so that there are safety versions of them. Both of those are available for you. We've got awareness stickers for you to stick on those spots that women, sometimes you see them on the back of bathroom doors in airports and things, places where women go where they're alone and they may be able to access information that they otherwise wouldn't be able to do. We do have some parts of the website that are still under construction. So in the meantime, if you go to the site and you're not able to get what you're looking for, feel free to reach out to me. I'm happy to share resources as we have them one by one, but you can also go to our project partners. SOAR has some great resources on their website, and the Abused and Brain Injured Toolkit has a great resource library that we've spent a lot of years putting together for you, where we have a lot of really good information for you there as well. I personally would like to thank all the survivors, frontline workers, community partners, healthcare providers, and supporters who've given us their time and insights over the years. We could not have done this work without you. I'd also like to thank the bold funders who saw the value in putting their money behind our collective projects. Justice Canada, Wage Canada, Public Health of Canada, Brain Injury Canada, Tri-Council funding through both CIHR and SSHRC, the Ontario Neurotrauma Foundation, and many more. We're very grateful for your financial support and your confidence in our ability to do good work. And we hope you continue to fund us. And I'd just like to close by saying thank you for joining us today. We've got a QR code here from Ava for feedback. And that's my part of the chat. So I'd love to hear from you and field any questions that you might have.
Thank you so much for your excellent and informative presentation on recognizing and responding to brain injury from intimate partner violence. And thank you for the valuable insights that you shared with the AVA webinar audience and the resources that you have recommended. And the first question that I have is from Alexandria, and she's wondering that she would like to learn more details about potential validated tools for detecting IPV brain injury.
So we don't actually have any tools that are validated that are designed for IPV-BI. We have many tools for brain injury to detect brain injury amongst folks that are validated. And what we've done is slightly adjusted those a little bit to be sensitive to the IPV context, but they haven't gone through a strict validation process. We do tend to rely on the updated HELPS tool, HELPS. You can get a copy of that on the SOAR website. They adapted that a number of years ago. They just tried to make it a little bit more IPV sensitive. It was a brain injury tool that was intended to be used by non-brain injury specialists just to do a quick assessment as to whether or not there was a possibility or a probability of a brain injury being at play and give you an indication of the next best steps. So once you understood that, what should you do next for your client in whatever capacity you were? And the folks over at SOAR adjusted that a little bit, made it a little bit more IPV sensitive. So at the moment, that's what we're recommending. Our team has been tasked by public health to address this, and our plan is to create an IPV-BI specific screening tool and to see what we can do about validating that within the sector.
Thank you. Thank you for describing your plans to develop a validated tool along with the current methods by which you employ to detect IPV-related brain injury. Also, I'm wondering, for organizations with limited resources or specialized training, what do you believe are the most important first steps they can take to better support survivors who may be living with an undiagnosed brain injury but are demonstrating some of the symptoms that you mentioned in the presentation?
So it kind of depends on what context they're coming from. But I think there are two or three really big ones to do. Um, Go back to that slide I've got that has the list, the dark purple one. It comes after that lovely little stack of stones on the beach, where folks can take a look at. There's very specific things that you can do that don't cost anything. So that's that limited resources piece. Just the way in which you speak with a client, the sorts of things that you change in how you organize your conversation with them, how you check in with them, whether or not they're remembering detail. Um, that would certainly go a long way to alleviating some of the brain injury related challenges. The flip side of that is if you're in that brain injury piece and you know all about how to work with folks with brain injuries, but you're feeling a little bit less secure on what are the implications of trauma and how's that going to play in, then that's really about that sort of piece around how you address people, the language that you use, getting that trauma informed training. I think it's really important that we focus on the cross pollination. We can't create an IPV-BI expert. A couple of teams have tried. They gave it a great test run of 5 years, and at the end of that 5 years, they determined that the subject matter is just too big. And we can have brain injury professionals, and we can have IPV professionals, but creating an IPV-BI professional is really difficult to do. So your best bet is that cross pollination piece. It's reaching out to your local shelter. If you're a brain injury support organization of some sort and you don't feel like you have enough understanding of IPV, reach out to your shelter and ask them to send somebody in to do some training with your team, and vice versa. I guarantee you that if the IPV shelter guys are reaching out to their local brain injury association and asking for information and education and training, the association is going to be really happy to be able to provide that. We've spent a decade getting folks up to speed on the intersection existing. And so I think there's a lot more understanding out there in the community of the pieces of the puzzle to this. We still need to get everybody talking to everybody else. We need those bridges in between the silos. The other thing that you can do is please reach out to us at the center. This is what we're supposed to do for the remaining 16 months of our project. Public Health of Canada is funding our time and our expertise. So we are engaging in an extensive education, training, awareness raising campaigns, and we'll be happy to come and do a training with your team anytime.
I really appreciate this, and I think we would definitely be interested in that. And it's very valuable to hear about the training that you provide to organizations. Thank you. And thank you so much for discussing your recommendations for organizations, especially those with limited resources, to better support survivors who might have an undiagnosed brain injury. And this next question follows from this first one, but what do you believe are the biggest barriers currently preventing IPV-related brain injuries from being recognized and addressed within healthcare, social service, and criminal justice systems?
I think the largest barriers really are the lack of awareness. Um, Up until 10 years ago, IPV brain injury didn't exist in the sense that nobody understood that the two things were related. And really, in the last 10 years, what we have done, what all of us in this field have done, is focused on very basic education, just getting recognition of the relationship between the two. Everybody understands about concussion in sports, right? Everybody knows about hockey players getting injured on the ice. The number of hockey players getting injured playing hockey in the NHL up against the number of women getting injured by an um, intimate partner violence, they're staggeringly different. So for one NHL player, we have thousands of women when you do the math. And I think we just need that recognition. We just need people to understand that this is real, that it's happening a lot. And then everybody from their own sector is coming forward saying, what do we need to know? How do we change things? How do we get that training? And because we are now in a position to be able to answer those questions and provide you with training and with resources in order to be able to do that, I think we've come an incredibly long way in the last 10 years. And I'm so excited to see where we're going to be in the next 10 years. Think I think we're on the cusp of that big wave of change, and it's tremendously satisfying to see that happening.
Sorry, absolutely. I'm very appreciative of your efforts, your organization's efforts to help influence and spur this needed change, and some good news that you shared with respect to the progress that's been made in recognizing IPV-related brain injuries over the last decade. And along these lines, my final question relates to what implications does the growing recognition of IPV-related brain injury have for police, courts, and victim services, particularly when survivors' memory, communication, or decision-making abilities may be affected by their injuries?
Well, this is where we start to see the policy implications. And my hope is that the wave that we've been building and that we're still seeing move forward continues to move into these areas. I think I think a declaration of intimate partner violence as an epidemic is an important step forward. I know we have a lot of communities doing that. I'd love to see more provinces doing it. I'd love to see a national statement on that. I think that opens doors for policy to be enacted and created addressing that. And part of that is in the legal sector and in policing, in law enforcement. Um, and again, it's an awareness. It's an understanding that just because the person that you're speaking to doesn't tell the same story twice, doesn't relate information in a linear fashion, doesn't always look you in the eye, and can be emotionally volatile, doesn't mean that they're lying or that they're trying to manipulate you and trying to take advantage of a situation. It can be as simple as a brain injury and those communication challenges that are coming to play. So I think what we need to see is an awful lot more education of judges and lawyers, so that when they're in the courtroom and these things are happening, it is understood that there is a disability related underlying cause, and that accommodation is made, and that we change the environment, we change our expectations about what that testimony is going to look like, what those pieces, what those actions, what those choices, that things that we have seen as choices, what those might look like in a survivor. And it changes the way that we expect someone to relate information and to behave. And once we have an understanding of that, like, just think back to the wheelchair, right? Nobody's going to ask somebody in a wheelchair to stand up and walk across a room. And I think we need to stop treating people with brain injuries in the same way. And we need to understand that they're going to have their own limitations and idiosyncrasies and unique qualities, and that we need to understand that and interact with them in such a way as to respect that and to accommodate that. Sorry, Jason, I think you're still muted.
I'm sorry. Thank you for explaining these implications related to the growing recognition of IPV-related brain injury, and for your valuable insights regarding the recognition and response to brain injury from intimate partner violence and the sharing the valuable work that your organization is doing pertaining to IPV brain injury related IPV brain injuries. And so thank you so much for your excellent presentation. I really appreciate this.
Thank you so much for the opportunity to do this and to share this information and just another platform to get more education and awareness. I think it's really important, and I'm very grateful to Ava for having us here today.
Thank you, and thank you so much for your valuable presentation as part of the AVA webinar Wednesday series. And so just some concluding notes for everyone, as you would have seen in the chat and also in accordance with this link, that there is the feedback survey, and subsequently this recording will be posted to AVA's YouTube channel for further reference. And I'd recommend that you continue to watch this presentation and examine the upcoming work that and ongoing work that the Center for IPV Brain Injury is undertaking. So thank you so much, everyone, for joining the webinar series today.